This talk is about infrequently preformed evoked potentials. It is intended for the Nicklaus Children's Hospital Clinical Neurophysiology Fellows. This talk will be conducted in a question and answer format. The first question: laser evoked potentials test dash fibers A delta, B C A gamma, D A beta. There are 4 frequently used nerve classifications that you can read in this frame. But I guess most neurophysiologists, when talking about evoked potentials, refer to the Kaiser Classification. So we will do the same in this talk. As far as I can tell, the Kaiser Classification originated in 1922 with the publication of this paper. I was very impressed the first time I read this paper when I saw the diagram of the oscilloscope used by Dr. Kaiser and Dr. Erlanger in their experiment. As you can see, it is quite a contraction. I am certainly disappointed with the photograph I have been able to find from this paper. It belongs to an action potential of the sciatic nerve of a frog, but I'm not quite sure. In a subsequent paper on the subject, this time with the help of George H. Bishop in 1924, the classification of action current of nerve was presented. Such classification divided nerves into A, B, and C and described 4 types of group A fibers: alpha, beta, gamma, and delta. The year is now 1930. In this paper, Dr. Erlanger was the first author. And in the introduction of this paper, they mentioned that in 1924 they designated the most constant and prominent conduction action potentials as alpha, beta, gamma, and delta, based in the order of their appearance, as we have just previously mentioned. Yet a footnote in the same introduction states that it would be best for the present to disregard delta waves. This is an oscilloscope recording from a photograph published in the 1930 paper. You can see an initial elevation labeled A with associated peaks: alpha, beta, and gamma. Another elevation labeled B, and another elevation, this one labeled C. In this new frame, I have included a picture of all the 1930 recordings. As you can see, delta is nowhere to be found. Come 1941, in a paper authored by Dr. Kaiser alone, he comments on adhering to the classification of group A fibers as alpha, beta, gamma, and delta. He also talks about the C on myelinated fibers and mentions the B fibers. He described the B fibers as being visceral fibers that are present in the sciatic nerve of frogs, but not in mammals. This is a photograph from this paper. it corresponds to the A fibers. And as you can see, they are labeled alpha, beta, gamma, and delta again. This study was done using the nerve from a rabbit. As you know, come 1944 and Dr. Erlanger and Dr. Kaiser are giving the Nobel Prize in Physiology or Medicine. I guess the Nobel Committee could not make up their minds. This prize was given for their work about the classification of nerve fibers based on size, neurophysiological characteristics, and conduction velocities. Now we go to 1960. This paper is published by Kaiser alone. Using the saphenous nerve of a cat. The delta waves are again mentioned, and there is no mention of A beta or A gamma fibers. In a previous video, the one on cutaneous stimulation, I gave a slightly different account of this story based on a paper on the subject written by Manzano and published in Archives of Neuropsychiatry in 2008. So it seems to me that the Kaiser classification was perfect in this fashion, but I remain wondering what had happened to the A beta and the A gamma fibers. Then I read Kimura's book and learned that in 1960 Kaiser had removed the gamma peak because it was an artifact. So there was no longer an A gamma fiber group in the Kaiser classification. But then A gamma fibers have been resurrected by some authors as the motor fibers that innervate the muscle spindles. So be it as it may, the fibers involved in the laser evoked potential studies are alpha delta fibers, once removed from the classification by Kaiser and then put back, and C fibers. Before leaving this subject, I'd like you to take a look at this figure. I am presenting it to you to give you an idea of the relative quantity of fibers that laser evoked potential activates. In a sensory nerve, more myelinated fibers are A delta fibers than alpha or beta fibers. And in addition, there are more C fibers than A delta fibers. Remember that A delta fibers conduct faster and make fewer synapses on the rostral trajectory than C fibers. That mean A delta and C fibers, are both slow in comparison with A alpha and A beta fibers. So the answer to this question is A. Next question. Laser evoked potentials test are the most reliable neurophysiological tool to investigate patients with neuropathic pain. A true, B false. Most neurophysiologists will say so. So the answer to this question is A. Next question. Which of the following is not a benefit of solid state laser stimulator? A. Narrower wavelength. B. Steeper slope. C. Deep skin penetration. D. Less skin pigmentation artifacts. Lasers generated by different methods have different wavelengths. There are two types often used to trigger evoked potentials. One is called CO2 laser stimulator and the other solid-state stimulator. There are significant differences between the two types. Laser CO2 produces waves of more than 3 micrometers, usually about 10 micrometers. Solid-state lasers produce waves of less than 3 micrometers. The slope is steeper with solid-state laser stimulation than with CO2 laser stimulation. The duration of the pulse can be shorter with solid-state laser than with CO2 stimulator. The penetration of the stimulus is deeper with solid-state laser than with CO2 laser. Solid-state laser stimulator produce more skin pigmented related artifacts, and they are available only at very few centers. So the answer to this question is D. Next question. Which is the most reliable and easy method to selectively test C fibers? A. Provide low intensity large area irradiation. B. Pressure block of A fibers using lidocaine injection. C. Averaging potentials occurring after 2 seconds. D. Pressure block of A fibers using a tourniquet. Laser evoked potentials result from activation of C fibers and A delta fibers. But using the usual protocols for laser evoked potentials, the cortical responses we obtain are primarily or exclusively the result of A delta activation. So special steps must be taken if we desire to analyze C fibers, which, as I told you a few minutes ago, are the most abundant fibers in sensory nerves. One of these methods is to use a low intensity pulse over a large area, thus overwhelming the activation of A delta fibers by the sheer volume of the more abundant C fibers. The other method consists of concentrating the stimulus to a very small area in the hope of only activating the more abundant C fibers. In addition, the analysis time when preferentially stimulating C fibers must be increased to about 1200 to 1500 milliseconds, since C fibers trigger potentials occur between 800 and 1000 milliseconds after the stimulus. So the answer to this question is A. Next question. Which of the following derivations show the highest wave with left hand stimulation using a solid state laser? A. ZC to nose. B. TA to nose. C. FP1 to nose. B. T4 to FP1. With solid state or CO2 laser stimulation, the highest amplitude wave, N2, is usually obtained using a ZC to nose derivation regardless of the region of the body being stimulated. The latency nonetheless varies according to the region and the type of stimulator. Laser evoked potentials N2 appear earlier when produced by solid state laser than when produced by CO2 laser. This is an example of solid-state laser evoked potential triggered by left-hand stimulation. As you can see, N2 occurred at about 220 milliseconds. Using CO2 laser stimulator, when the stimulus is in the phase, the usual latency to N2 is from 150 to 250 milliseconds. When the stimulus is in the hand, N2 occurs at about 220 to 340 milliseconds. And when the stimulus is in the region of the foot, the latency to N2 ranges from 290 to 380 milliseconds. The cortical generator of N2 and P2 are the middle part of the cingulate gyrus with variable contribution from the insula and the frontal operculum. So the answer to this question is A. Next question. Which of the following is not true regarding earlier components of laser evoked potentials? A. Occur between 150 to 180 milliseconds after hand stimulation. B. Inverts polarity between temporal and vertex electrodes. C. Involve the cingulate gyrus. D. It is less influenced by attention. An earlier, smaller negative wave than N2 is obtained in the hemisphere opposite to the stimulus during laser stimulation. This wave is often called the opercular N1. The cortical generators of this wave are the upper bank of the Sylvian fissure, the posterior insula, with some contribution from the primary somatosensory cortex. This negative wave is captured using T4 to nose derivation in the case of left hand stimulation. N1 inverts using an ipsilateral, in this case right frontal electrode connected to the nose. Hence, the use of contralateral temporal to ipsilateral frontal derivation produces a taller and sharper wave in most instances. This wave is less sensitive to changes in attention than N2, and some neurophysiologists feel once more data is collected will be a good parameter to analyze. So the answer to this question is C. Next question. The recommended montage for laser evoked potentials consists of all of the following except A. FC to nose, B. ZC to nose, C. TC to FC, D. mastoid to nose. The recommended montage consists of a total of 4 derivations. The first derivation is from ZC to nose. The second derivation goes from FC to nose electrode. The third derivation from the temporal region contralateral to the stimulus to the mid-frontal region or the opposite frontal region. The fourth derivation goes from an electrode 1 centimeter below the lower eyelid on the site of the stimulus to the nose or to the FC electrode. The ground electrode can be placed over the mastoid. So the answer to this question is D. Next question. Which of the following technical considerations is not true? A. Low frequency filter 0.1, high frequency filter 200 Hz, no narrower than 0.3 to 30 Hz. B. 2 runs of 20 to 30 stimuli usually suffice. C. Stimulus at intervals more than 6 seconds should be used. D. Earplugs should not be used. The recommended filters for laser evoked potentials are a low frequency filter of 0.1 Hz and a high frequency filter of 200 Hz. These capture a wide range of activity. Some investigators like to restrict the range of activity captured in the cortical potentials by using a low frequency filter of 0.3 and a high frequency filter of 30 Hz. Earplugs are needed because the laser stimulator makes a noise with each stimulus. The interval between stimulus should be more than 6 seconds. The stimulus delivered at intervals of less than 6 seconds produce habituation and alter the timing and amplitude of N2. Some patients do better with the eyes open while others do better with the eyes closed. Patients with eye open tend to blink. Patients with eye closed tend to produce alpha activity. Usually 2 runs of 20 to 30 stimuli suffice to obtain clear recordings. So the answer to this question is D. Next question. Which of these statements is not true? A. Patients with psychogenic hyperalgia have normal laser evoked potentials. B. Pure spinothalamic lesions affect laser evoked potentials and not somatosensory evoked potentials. D. Small fiber neuropathy affects laser evoked potentials and not somatosensory evoked potentials. D. Syringomyelia affects somatosensory evoked potentials sooner than laser evoked potentials. Patients with psychogenic hyperalgia have normal laser evoked potentials, but more importantly, patients with abnormal laser evoked potentials have organic involvement of the spinothalamic system. Neuropathy involving only small fibers affect laser evoked potentials and not somatosensory evoked potentials. A pure spinothalamic lesion affects laser evoked potential and spares somatosensory evoked potential. Syringomyelia affects laser evoked potential before somatosensory evoked potentials because the thalamic fibers cross to the opposite side within the spine, and therefore these fibers get affected before by the expanding syrinx. So the answer to this question is D. The loss of N13, median nerve somatosensory evoked potential, and N22, posterior tibial nerve somatosensory evoked potential, often occurs in conjunction with the loss of laser evoked potentials of the upper and lower extremities, respectively. A true, B false. This is a representation of the right dorsal quadrant of a spinal cord. In this frame, I have indicated the dorsal ganglia. The curvy yellow lines represent the nerves, and the thicker yellow line represents fibers contributing to the cuneatus tract on the way towards the brainstem. In this frame, I have indicated the proximal axon of the dorsal ganglion neurons. And here a bunch of fibers traveling in the cuneatus fascicle. Although the bulk of the fibers in this fascicle continues towards the brainstem, some of them have shoots that go laterally and synapse with cells in the dorsal horn. Mainly, they synapse in the rest lamina 4 and 5. These synapses are primarily with neurons involved in the production of spinal reflexes, and their activation occurs following a 0.4 to 0.6 millisecond delay. That is the delay that usually occurs in most synaptic transmissions. This delay is important because the activation of the different segments of the track, as I am representing here by the blue starburst, and here, and here. But notice that in this figure I have also introduced another blue starburst in the first spinal segment to indicate that a synaptic potential in this segment is occurring while the traveling volley is far more rostally. A point of interest is that, as you remember, N13 and N22 are generated in the dorsal horns following medial and posterior tibial nerve stimulation, and that alpha delta fibers and C fibers also synapse with neurons in the dorsal horn at the rexate lamina 1 or 2, from where the spinothalamic tract originates. So the answer to this question is A. Next question. Pudendal somatosensory evoked potentials add clinically valuable information in the evaluation of erectile dysfunction. A true, B false. This is a diagram of the pudendal nerve. As you can see, it arises from the sacral segments 2, 3, and 4. The cortical potentials generated by its stimulation are obtained by placing the exploratory electrode at the CPZ location and the reference electrode in the FZ location. It usually takes about 500 stimulations to get a clear response. This stimulation should have a duration of 0.1 millisecond, be given at intervals of about 500 milliseconds, with an intensity of 3 times the sensory threshold in order to generate an acceptable pudendal somatosensory evoked potential at the scalp. Most consider a latency of more than 7 milliseconds the latency of the posterior tibial nerve, P37 or P39, abnormal. A study published in 1995 revealed that patients with sexual dysfunction and normal neurological exams have normal pudendal somatosensory evoked potential, whereas those with abnormal neurological exams had abnormal somatosensory evoked potential. Though it has been suggested that the study of the pudendal nerve using SSEP adds little to the evaluation of patients with erectile dysfunction. Pudendal somatosensory evoked potential have a place in the evaluation of pelvic floor disorders and have high sensitivity for diabetic neuropathy and spinal cord injuries. So the answer to this question is B. Next question. Trigeminal electrical stimulation could be achieved with all of the following except A. Facial surface electrode. B. Needle electrodes. C. Gum and teeth stimulation. D. Vertex stimulation. Trigeminal electrical stimulation can be delivered at any trigeminal sensory area. Here, the arrow is pointing to the infraorbital region, but it can also be delivered at the supraorbital region or at the mental region. Trigeminal electrical stimulation can also be delivered at the gums. So the answer to this question is D. Next question. Direct electrical stimulation of the teeth elicit muscle twitches from 0 to 10 milliseconds and sensory reflexes after 10 milliseconds. A. True. B. False. Facial surface stimulation produces motor artifacts due to the unintended activation of facial nerve fibers and due to reflex muscle contraction triggered by sensory mediated reflexes. The artifacts due to muscle contraction resulting from unintended facial nerve stimulation occur in the first 10 milliseconds following stimulus. The artifact resulting from sensory reflexes occurred after 10 milliseconds. Gums and teeth stimulation produces sensory mediated artifacts only. Infraorbital nerve stimulation using needles produces a far field that can be captured at the vertex. The direct stimulation of the trigeminal nerve obviates unintended facial motor fibers stimulation and occurs so rapidly that the field it produces at the level of the entry zone of the trigeminal nerve into the pons occurs prior to it triggering any sensory reflex, and therefore the artifacts that go with them. So the answer to this question is B. Next question. Persistent facial pain in a patient with trigeminal neuralgia after radiotherapy thermocoagulation of the Gasserian ganglion is an indication for trigeminal SSEP. A. True. B. False. In this frame, you can see a study that was performed in a patient with right trigeminal neuralgia. It was normal. The absolute latency to W2 and W3 is the same on both sides, and the amplitude of W2 and W3 waves is normal. So is the interval between W2 and W3. This study was done after radiofrequency thermocoagulation of the right Gasserian ganglion. Notice the latency to W2, amplitude of W2, and the interpeak latency between W2 and W3. In this frame, by using the yellow lines at the base and the vertical green line vertically from it, I am trying to show the difference in amplitude between the normal side and the abnormal side. Notice that on the left, the W2 is always taller than W3. But this is not so on the right where the surgery was performed. Also notice the absolute latency to W2 is increased on the right, notice that from the horizontal dot to the horizontal dot there are 30 milliseconds. And also notice that the interval latency between W2 and W3 is increased after surgery on the right side. Interestingly enough, the unmarked wave after W3 is not present on the right. This wave is not used for analysis. Persistence of pain in such a case, in the presence of these postsurgical findings, would not be because of failure of surgery, since there is evidence that the Gasserian ganglion has been made not functional by the treatment. So the answer to this question is A. Next question. Trigeminal laser evoked potentials most of the time do not trigger sensory reflex or motor activity. A true, B false. No sensory reflex or motor activation occurs with laser evoked potential most of the time. So the answer to this question is A. Next question. Trigeminal laser evoked potentials can be used during surgery for epilepsy to map the facial area. A true, B false. In this article, laser somatosensory evoked potentials were used to map the facial area, and this was compared with the results of cortical activation done using intracranial electrodes. Initially, scalp recorded laser evoked potentials were obtained using a montage with two derivations. The first derivation connected one electrode from ZZ to a reference electrode that consisted of link ears. The second derivation consisted of an exploring electrode in the contralateral central region connected to the same link ear electrodes. But more interesting than the amplitude of N2 and P2 present in the scalp recording was the matching of the electrical cortical localization using implanted left frontotemporal subdural electrodes and the laser evoked potential amplitude in these two patients. The amplitude was measured after stimulation of the face. The stimulation was done contralaterally and ipsilaterally to the stimulus, and also was done using the ipsilateral and the contralateral arm. In this frame, I'm only presenting the facial stimulations and the stimulation from the contralateral arm. Take a few minutes if you're interested to read the legend in this frame and look at the figures. What I found most interesting was the combination of multiple methods to study brain localization, and that laser stimulation of the ipsilateral side to the stimulation was able to produce activation of the grid. So the answer to this question is A. Next question. Late components N2 and P2 are found to be the most reliable parameters for analysis of trigeminal nerve somatosensory evoked potentials. A true, B false. Trigeminal nerve somatosensory evoked potential can be recorded using subcutaneous electrodes, as it is inferred in this diagram. The specification used for this study are presented in this frame. In this case, the mental nerve was stimulated, placing the cathode of the stimulator over it. The patient had a history of left facial numbness. He also had a blink reflex test that showed absence of R1 with left-sided stimulation and an MRI that showed a lesion in the left mesencephalus. You can see both of these studies in this frame. This new frame shows the result of the trigeminal somatosensory evoked potential. Please take a few seconds to look at the normal result following the stimulation of the right trigeminal nerve and compare it with the result encountered after stimulation of the left trigeminal nerve. This study is from another patient, another article. It shows the difference between cortical responses of an affected right trigeminal nerve and of an unaffected left trigeminal nerve. As you can see in this frame, this difference is very marked in this study. It is important to remember that the most important parameter to analyze when looking at trigeminal nerve somatosensory evoked potential is N2 and P2. And it's also good to remember that some authors use the term W2 to refer to the N2 and P2 combined. So the answer to this question is A. Next question. Trigeminal somatosensory evoked potential is the best method for trigeminal nerve functional assessment. A true, B false. Despite the examples I have just shown you, the conclusion from Krukus' paper, which I highly recommend you read it, is that trigeminal reflexes are the way to go for trigeminal functional assessment rather than trigeminal evoked potential studies. So the answer to this question is B. Thank you very much for your attention.